Hello all, I am here to present a seminar about temporomandibular joint. This is Dr. Arun Krishnan, Department of IMFS, Sri Balaji General Hospital. So before moving on to the disorders, we will have a brief small discussion about what is TMJ. The temporomandibular joint is located anterior to the tragus of the ear. It's considered as an articulation between the base of the skull and the condyle of the mandible. The articular surface is the squamous part of the temporal bone. It consists of the articular fossa, glenoid fossa is concave, articular tubercular eminence convex, condyle of the mandible, articular disc, joint capsule and ligaments. The classification of the temporal mandibular disorders are masticatory muscle disorders, disc interference disorders, internal derangement, external derangement. So masticatory muscle disorders, productive muscle splinting, muscle hyperactivity or spasm, myositis, muscle inflammation. Under the internal derangements, deformation of the articular disc, partial anterior disc displacement with reduction, without reduction, anterior disc displacement with perforation, posterior disc displacement. The problems that result from the extrinsic trauma, tendinitis, myositis, traumatic arthritis, dislocation, fracture and internal derangements. The degenerative joint diseases are the arthrosis, non-inflammatory phase, osteoarthritis, inflammatory phase, osteochondritis or avascular necrosis. Inflammatory joint disease disorders, synovitis and capsulitis, retrodiscitis, inflammatory arthritis, rheumatoid, infectious and metabolic arthritis, chronic mandibular hypermobility, ankylosis, fibrous or osseous, fibrosis of the articular capsule, contracture of the elevator muscles, myostatic and myofibrotic, internal disc derangement, closed law. Growth disorders of the joint, developmental disorders, acute disorders, neoplastic disorders, post-surgical problems. So first, moving on to the arthritis of the temporomandibular joint. It's a degenerative joint disease known as osteoarthritis, also referred as osteoarthrosis, osteoarthritis, and degenerative arthritis. Is primarily disorder of the articular cartilage and subchondral bone with secondary inflammation of the synovial membrane. So you can see in this picture, it is a localized joint disease without systemic manifestation. This process begins in loaded articular cartilage with stents and clefts, fibrillation, then breaks away during joint activity. This leads to sclerosis of the underlying bone, subcondylar cyst, and osteophyte function. Causes of osteoarthritis is essentially a response of the joint to the chronic microtrauma or pressure. The microtrauma may be in the form of continuous abrasion of the articular surfaces as a natural wear associated with the age or as an increased loading forces, possibly related to the chronic parafunctional activity. The fibrous tissue covering in patients with degenerative disease is preserved. Types of degenerative joint disease. It may be say primary or secondary. Primary disease of unknown origin, but genetic factors plays an important role. It is often asymptomatic and is commonly seen in patients above the age of 50 years. Secondary disease results from a known underlying cause such as trauma, congenital dysplasia, or metabolic causes. Clinical features. The degenerative joint disease, the DMJ, begins early and has been observed in over 20% of joint individuals over the age of 20 years. Many patients with mild to moderate degenerative joint disease, the DMJ, have no symptoms, although arthritic changes are observed on radiographs. The presence of pain in patients with degenerative joint disease associated with inflammation and joint effusions. So these are the clinical pictures and radiographic pictures of how the arthritis look. The clinical features, the patient is symptomatic degenerative joint disease of the DMJ experience, unilateral pain directly over the condyle, the limitations of the mandibular opening, crepitus, feeling of stiffness after a period of inactivity, lateral palpation of the condyle increases as pain increases. Radiographic features, narrow joint space, flattening and subchondral sclerosis, loss of the cortex and the erosion of the articular surface of the condyle are the most important characteristics. Treatment. Coming to the treatment, degenerative joint disease of the DMJ can usually be managed by a conservative treatment. Significant improvement is noted in many patients after 9 months, and the burning out of many cases occurs after 1 year. It seems prudent to manage the patient with conservative management. So at initial line of management is conservative for first 6 months to 1 year before considering surgery unless severe pain or dysfunction persists after an adequate trial of non-surgical therapy. Conservative treatment includes non-steroidal NSAIDs, heat, soft diet, rest, and occlusal spins that allows free movement of the mandible. It may also necessary to prevent. It may also be necessary to treat the myofascial pain and meniscal defects. Intra-articular steroids can be used during acute episodes, but there is concern that repeated injection may cause degenerative bony changes. Preliminary reports suggest that anti-inflammatory effects of doxycycline therapy may be helpful in treating the pain associated with temporomandibular joint disorders. Surgical treatment and the TMJ pain or significant loss of function persists, and when Distinct radiographic evidence of the degenerative joint changes exists. Surgery is indicated. And arthroplasty, which limits surgery to the removal of the osteophage and erosive areas, is commonly performed. Rheumatoid arthritis. The percentage of rheumatoid arthritis patients with TMJ involvement ranges from 40 to 80% depending on the group studied and the imaging techniques used. The disease process starts as a vasculitis of the synovial membrane. It progresses to chronic inflammation marked by an intense round cell infiltrate. Subsequent formation of the granulation tissue. The cellular infiltrate spreads to the articular surfaces, eventually to cause an erosion of the underlying bone. So this is the normal joint. This is the joint affected by the rheumatoid arthritis, and bone loss and cartilage and erosion can be seen. Generalized bone loss will be evident. Inflamed synovium and swollen joint capsule. Clinical manifestations. The TMJs are usually bilaterally involved in rheumatoid arthritis. Most common symptoms include limitation of the mandibular opening and joint pain. Pain is usually associated with the early acute phases of the disease, but is not a common complaint in later stages. Morning stiffness, joint sounds, and tenderness and swelling over the joint area. The symptoms are usually transient in nature, and only a small percentage of patients with rheumatoid arthritis TMJ will see permanent clinically significant disability. The most consistent clinical findings include pain on the palpation of joints and limitation of opening. Crepitus may also be evident. Micrognathia and an anterior open bite are commonly seen in patients with rheumatoid arthritis. And micrognathia is a combination of direct injury to the condylar head and altered orofacial muscular activity. Ankylosis, the DMJ related to the rheumatoid arthritis, is rare. So these are the deformities on the structural basis can be seen in this picture. The other clinical picture is anterior open bite, proclined upper anterior rheumatoid arthritis. The radiographic changes are sharpened pencil mouthpiece of the flute. The radiographic changes in the TMJ associated with the rheumatoid arthritis may include a narrow joint space, distracted lesion of the condyle, and limited condylar movements. Little evidence of marginal proliferation or other reparative activity in the rheumatoid arthritis, in contrast to the radiographic changes often observed in the degenerative joint diseases. High resolution CT will usually show erosion of the condyle and granite fossa, which cannot be seen by the conventional radiographs. Treatment for RA: anti-inflammatory drugs and congestion of the therapy for other affected joints. Soft diet during acute exacerbation of the disease process, but IMF is to be avoided because of high risk of fibrous ankylosing. Flat plane occlusion appliance may be helpful, particularly if parafunctional habits are exhibiting the symptoms. Exercise program to increase the mandibular movement should be instituted. Intra-articular steroid should be considered. Processes appear to decrease symptoms in fully or partially adhered patients. Surgical management. Placement of prosthetic joints is indicated to have functional impairment or intractable pain not successfully managed by other conservative managements. So juvenile rheumatoid arthritis, as known as Still's disease, chronic inflammatory disease that appears before the age of 16 years. It is characterized by chronic intermittent synovial inflammation that results in synovial hypertrophy, joint effusion, and swollen painful joint. Gradually, the cartilage and the bone are destroyed. Clinical features: pain and tenderness in the affected joints, unilateral onset, severe TMJ involvement may cause restricted mandibular growth, bird face appearance. Septic arthritis. The septic arthritis of the TMJs most commonly occurs in patients with previously existing joint disease such as rheumatoid arthritis or underlying medical disorders, particularly diabetes. Patients receiving immunosuppressive drugs or long-term corticosteroids also have an increased incidence of septic arthritis. The infection of the TMJ may result from blood-borne bacterial infection or by the extension of the infection from adjacent sites such as middle ear, maxillary molars, and parotid gland. Organism responsible: gonococci are the primary blood-borne agents causing septic arthritis in the previously normal TMJ, while Staphylococcus aureus is most common organism involved in previously arthritic joint. Clinical symptoms of SA. The TMJ includes trismus, deviation of the mandible to the affected site, severe pain on movement, and an inability to occlude the teeth owing to the presence of inflammation of joint spaces. Examine. How to examine? Examination. Clinical examination reveals redness and swelling in the region of the affected joint. Swelling may be fluctuant and extend beyond the region of the joint. Large, tender cervical lymph nodes are frequently observed on the site of the infection. This helps to distinguish between septic arthritis and more common types of TMJ disorders. Diagnosis is made with detection of the bacteria and gram stains, either the Staphylococcus aureus or gonococci, and the culture of the aspirated TMJ fluid. Sequelae. Serious sequelae includes osteomyelitis of the temporal bone, brain abscess, ankylosis. Facial asymmetry may accompany septic arthritis of the TMJ, especially in children. Juvenile septic arthritis. The primary sources of this infection were the middle ear and the hematological spread of the gonorrhea. Evaluation of the patient with suspected arthritis must include a review of signs and symptoms of gonorrhea such as fluid urethral discharge or dysuria. The affected TMJ should be aspirated and the fluid obtained tested by gram stains and especially cultured for Neisseria gonorrhea. Treatment. The treatment of septic arthritis of the TMJ consists of surgical drainage, joint irrigation, and 4 to 6 weeks of antibiotics. Moving on, so now we have completed about the arthritis, rheumatoid arthritis, juvenile arthritis. Moving on to gout and pseudo gout. Gouty arthritis is caused by long-term elevation of serum urate level, which results in deposition of crystals in the joint, triggering an acute inflammatory response. Acute pain in a single joint, monoarticular arthritis is the characteristic clinical manifestation of gouty arthritis. Physiologic disposition. So normal picture indicates about the physiologic disposition. Internal derangement. The classification of disc displacement based on the direction of disc: anterior, anteromedial, medial rotatory, lateral rotatory, anterolateral, medial, lateral, posterior. The normal disc position in sagittal oblique closed mouth position in MRI. Functional classification of disc displacement. So this is the normally widely classified about the used classification of disc displacement. Grade 0, normally placed disc. Grade 1, anterior disc displacement of the morphologically normal disc with reduction in mouth opening. Grade 2, anterior displacement without reduction on mouth opening, disc is morphologically normal. Grade 3, anterior displaced, non-reducing on mouth opening, morphologically abnormal disc. According to the clinical course, acute reducible, normal morphology and size of the disc, subacute, irreducible disc with deformity seen, chronic, irreducible disc with fibrosis, calcification and perforation with degenerative joint diseases. Clinical features. The most common symptoms of the internal derangements are pain, muscular tenderness, clicking and popping sensation within the joint, headache, earache, limited inability to open the jaw. Wilks signs and symptoms: pain in the joint area with variable radiation to the ear, temporal and cervical areas, tenderness in the joint areas and associated musculature, temporal headache, changes in the occlusion in acute cases with static mandibular shift to the opposite side and inability to approximate the posterior teeth. Restriction of the motion, both vertical and lateral, clicking, reciprocal clicking, closed locking. So this is present as closed locking, clicking, associated intermediate stage, final stages, fine and coarse crepitus. So the clinical stages in internal derangement: stage 1 with reduction, stage 2 with reduction and intermittent locking, stage 2, 3 without reduction, as you see in the previous picture, closed lock, stage 4 without reduction and with perforation or posterior attachment disease or degenerative joint disease. Disc displacement with degenerative joint disease is stage 4. Etiology of the internal derangement: trauma, occlusal disharmony, osteoarthritis, and stress. Posterior disc displacement, it's classified into 3 categories: thin flat disc, grossly posterior displaced disc, perforated disc with portion of the disc displaced posteriorly. Posterior disc displacement: loss of the disc contour anteriorly predisposes to posterior displacement of the articular disc. Disc occupies abnormal position related to the condyle in the resting closed joint position. As the condyle moves forward, the elastic traction of the superior discal lamina displaces the disc posteriorly. Imaging of the disc, orthography, MRI. Definitive treatment for disc dislocation with reduction. Definitive treatment for the disc displacement is to re-establish a normal condyle disc relationship. Ferrar introduced the anterior positioning appliances. This appliance provides an occlusal relationship that requires the mandible to be maintained in the forward position. This is the stabilization splint, as we can see in this picture, in order to provide normal movement of the TMJ. Supported therapy: soft diet, slow chewing, smaller bites, NSAIDs in the case of inflammation, heat or ice application. Active exercises are not helpful as it increases the pain. Passive jaw movements may be helpful. Treatment of the disc dislocation without reduction. Anterior positioning appliances is contraindicated as it aggravates the condition by forcing the disc even more forward. As a general rule, when patient reports an history of being locked for 1 week or less, manipulation is usually very unsuccessful. Management of TMJ disorders and occlusion: maximum mouth opening is seen. The clinician's right thumb is placed intraorally over the patient's left mandibular second molar and the mandible is grasped as seen in the picture, with the left hand stabilizing the cranium. Gentle but firm forces applied downwards on the molar and the upward pressure used on the chin to distract it. As you can see in this pressure, no pressure is given. Once the joint is distracted, the mandible is then brought forward. After the distraction, the thumb is removed and the patient is asked to close on the anterior teeth, maintaining the jaw in a slightly protrusive position. When the patient has rested a moment, The patient is asked to open the mouth. If the disc is reduced, maximal opening occurs. Supported therapy, avoid excessive opening, soft diet, slow chewing, smaller bites, NSAIDs in the case of inflammation, heat or ice application. Surgical treatment, a definitive treatment for derangements, it is considered once the conservative treatment gets failed. Arthrocentesis, this is the most important management or treatment for the two needles are placed into the joint and the sterile saline is passed through to lavage joint. Lavage is thought to eliminate the algogenic substances and secondary inflammatory mediators which causes pain, allogenic. Long-term effect is positive. Arthrocentesis, in case of the disc dislocation without reduction, a single needle can be introduced to the joint and fluid can be forced into the space in an attempt to free the articular surfaces. This is known as the pumping the joint. It improves the success of manual manipulation for a closed lock. Arthroscopy, an arthroscope is placed into the superior joint space and intracapsular structures are visualized on the monitor. Joint adhesions can be identified and eliminated and a joint can be significantly mobilized. It does not correct the disc position. Instead, success is more likely to achieved by improving the mobility. Arthrotomy, open joint surgery is called as an arthrotomy. When a disc is displaced or dislocated, the most conservative surgical procedure is a disc repair or plication. During plication of the portion of the retrodiscal tissue, an inferior lamina is removed and the disc is retracted posteriorly and secured with sutures. Discectomy, removal of the disc causes bone to contact and causes osteoarthritic changes. Silastic has been placed in the place of disc. Proplast Teflon discal implants have been used, but it leads to inflammatory reactions. Dermal temporal fascia flaps and auricular cartilage grafts have also been used. Complications of further surgeries: scarring restricts mandibular movements, post-surgical adhesions, mainly damage to the facial nerve. Moving on to the trauma affecting the TMJ. Fractures. The fracture of the condylar head and neck often results from blow to chin. The patient of the condylar fracture usually presents with pain and edema of the joint area and limitation and deviation of the mandible to the injured side and opening. Bilateral condylar fractures may result in anterior opening. Fracture of the condyle. The diagnosis of the condylar fracture is confirmed by radiographic examination. Intracapsular non-displaced fracture of the condylar head are usually not treated surgically. Early mobilization of the mandible is emphasized to prevent bony or fibrous. So, classification of the condylar neck fractures: 1. Virtual fracture of the neck but without displacement. 2. Lower neck fractures with displacement. 3. Fractures high on the neck with anterior, posterior, medial or lateral displacement. 4 is lower neck fracture with separation. 5 is higher neck fracture with displacement. 6 is fracture of the head of the condyle within the capsule. Developmental disorders of the TMJ. Common growth disturbance of the bone includes agenesis, hyperplasia, hyperplasia, neoplasia. Congenital and developmental bone disorders. Hyperplasia of the condyle. True condylar hyperplasia usually occurs after the puberty and is completed by 18 to 25 years of age. Limitation of opening, deviation of the mandible to the side of the enlarged condyle, and the facial asymmetry may be observed. Pain is occasionally associated with the hyperplastic condyle on opening. Hyperplasia of the condyle, facial asymmetry often results from disturbances in the condylar growth because the condyle is considered to be a site for compensatory growth and adaptive remodeling. Facial deformities associated with the condylar hyperplasia involve the formation of an convex ramus on the affected side and a concave shape on the normal side. If the condylar hyperplasia is detected and surgically corrected early stage, the facial deformity may be prevented. This picture indicates the condylar hyperplasia. Hyperplasia of the condyle, the name indicates the deviation of the mandible to the affected side, and facial deformities are also associated with the unilateral agenesis and hyperplasia of the condyle. In case of hyperplasia, it's a short, wider ramus, shortening of the body of the mandible, an antegonial notching on the affected side with elongation of the mandibular body and flatnesses of the face of the opposite. Condylar hyperplasia. Early surgical intervention is again emphasized to limit facial deformity. Rib grafts have been used to replace the missing condyle to minimize the facial asymmetry in agenesis. This is the condylar hyperplasia. It's diffusion in growth in condyle. Spontaneous dislocation is also known as open lock. It can open after wide open mouth procedures or yawning. This condition refers to spontaneous dislocation of both the condyle and disc. A direct punch or a kick to the mandible causes dislocation, opening the mouth wide on yawning or eating. Excessive laxity of the capsule and its ligaments, which allows capsular movement. Intubation during general anesthesia. Clinical characteristics: wide open mouth. Pain is usually commonly present secondary to the patient's attempt to close the mouth. So this is a dislocation as condyle gets dislocated. Definite treatment: when the attempts are being made to reduce the dislocation, the patient must open widely. This will activate the mandibular depressors and inhibit the elevators. At the same time, slight posterior pressure applied to the chin will sometimes reduce a spontaneous dislocation. If this is not successful, the clinician's thumbs are placed on the mandibular molars and downward pressure is exerted as the patient yawns. The initial thumbs should be covered with gauze. If the dislocation still continues, it is appropriate to inject the lateral pterygoid with local anesthetic without a vasoconstrictor in an attempt to eliminate the myospasms and promote relaxation. The definitive treatment: if the dislocation still continues, it is appropriate to inject the lateral pterygoid with local anesthetic without a vasoconstrictor in an attempt to eliminate the myospasms and promote the relaxation. Chronic or recurrent dislocation, surgical procedure like eminectomy. Best approach has been to inject the botulinum toxin to the inferior lateral pterygoid muscles. Patients should be recalled in 3 to 4 months. Supportive treatment. Prevention is best supportive treatment. Proper education is to the patient. Patient must learn to restrict the opening so as not to reach the point of translation that initiates interferences. Patients will be taught direct procedure. Subluxation is also known as hypermobility. Clinical description of the condyle as it moves anterior to the crest of the articular eminence, not a pathological condition but reflects a variation in the anatomic form of the fossa. Causes: results of anatomic form of the fossa: steep, short posterior slope of the articular eminence followed by longer, flat anterior slope claims to have great energy for subluxation. Disc is maximally rotated in the condyle before full transverse of the condyle disc complex occurs. Clinical characteristics: during the final stage of the maximum mouth opening, the condyle can be seen to suddenly jump forward with the touch sensation, which is not reported to be subtle clicking sensation. Treatment: ideal treatment, eminectomy, which reduces the steepness of the articular eminence and thus decreases the amount of posterior rotation on the disc on the condyle during full translation. Supportive treatment: proper education, must learn to restrict opening so not reach the point of translation that initiates the interferences. Wearing the device limits the opening of more subluxation. The device is worn for 2 months continuously and removed. So now moving on to the ankylosis. The ankylosis means abnormal immobility of a joint. 2 types: fibrous and bony. Bony, it occurs between the condyle and fossa, therefore the disc would have to be lost already from discal space. They are rare. Chronic and extensive disorder may cause bony ankylosis. This is the bony ankylosis picture. As you can see, appreciate both the bony ankylosis. Cause: hematorosis secondary to the macrotrauma. Fibrous ankylosis presents and continued progressive joint adhesions that creates a significant limitation of joint movement. Chronic inflammation aggravates the disorder, leading to development of more fibrous tissue. History: limited mouth opening, absence of pain, problem present for long period of time. Clinical characteristics: condyles can still rotate with some degree of restriction and inferior surface of disc. The patient is usually able to open approximately 25 mm interincisally. Lateral movements are restricted. Restricted movements to the unaffected side. During mouth opening to the opening, the pathway deflects to the lateral side. So this picture indicates about the right condyle ankylosis. So treatment: the compromised function warrants surgery. Arthroscopic surgery is the least aggressive surgical procedure. Gap arthroplasty is one of the most treatment followed by ankylosis. So the supportive treatment is generally not indicated. If mandible is forced beyond its restriction, injury to the tissue can occur. Analgesics and deep heat therapy can also be used. So in this we discuss about the normal anatomy of the TMJ, function, what and all the TMJ temperament of joint function disorders, disc derangements, and regarding the ankylosis, etc.